Welcome back to Fertility Fact or Fiction, the show where we bring you all the latest and greatest, and Tarek right in the way.
Yeah, just noticed that.
Your whole head just went right in front of the camera.
Get people excited.
So we had no show last week because I attempted to take a holiday, which was significantly interjected or interrupted by a family emergency. Everyone is well. Thank you to all of you for your very kind well wishes. We did have a little mishap out there and needed some emergency surgery, but it wasn't for me, just a family member, and that individual is doing well and recovering. So we managed to have a great holiday the rest of the time. I ate way too much and now I gotta work it all off in the next couple of weeks. So thank you for all your amazing well wishes and concern, much appreciated. I hope you guys had a good 2 weeks, and we're going to be back in action until the first week of August, and we'll probably do a live show from Michigan at that point. So until then, we'll be here every week again. Because I just literally got off a plane from Vancouver, I don't have a paper for you this week. So we're just going to dive right into questions. Hopefully we'll finish up by 9, and if you guys have anything specific you want me to touch on or talk about, I'm happy to do so. So we can go over anything you want to review and go over all the details. And I think there was one person that was going to ask a question on the private account, so you might be able to find it on there. And we'll look that up for you. So yeah, we have some questions lined up, but for those of you that want to ask your questions now, go ahead. If not, I can certainly talk about ovarian cysts and surgery. So one thing that can happen in the fertility world or gynecologic world is if you have an ovarian cyst, one of the risks of having a cyst is an ovarian torsion. That's when the ovary turns. And depending on how many times it turns, it can be extraordinarily painful, and it can cause ischemia to the ovary, meaning that your ovary is not receiving the blood and oxygen that it needs. And as a result, it can look quite black and ugly, dark, necrotic, kind of dead-like when you go in there to operate. It's usually caused when you have a cyst, and typically if the cyst is larger than 5 centimeters, you're at risk. If it's larger than 10 centimeters, you're at quite a bit of risk. So those are the ones where we need to operate in order to avoid the cyst from twisting on its blood supply. In the past, and I mean a long time ago, they used to just remove those ovaries because they would be concerned that the ovary would not recover. But the truth is that depending on how bad the torsion is, a lot of the ovaries do recover. And now how much is the function going to recover fully? We don't know. There haven't been studies of that, but there are what they call second look laparoscopies where people have gone back in afterwards to look at an ovary that they simply untwisted and maybe took out the cyst on. And then the ovaries look completely normal. So the procedure now is that we just untwist the ovaries and we leave them alone. Now, in the fertility world, there's a lot of worry from fertility centers about surgery. A lot of fertility specialists have lost their surgical skills or just don't have the time to do surgery anymore and are super focused on just, the IVF grinder, as I like to call it, so everybody's getting IVF. So a lot of patients with endometriomas, dermoids, follicular cysts, persistent corpus luteum, are left with them and told they should not have surgery. Now, there is a rationale behind that, and that is that there are many studies that show that if you remove cysts, in particular endometriomas, from the ovary will transiently weaken. So you can diminish your ovarian reserve by operating on the ovary. So personally, there are 2 reasons I don't really follow that. Number one, there are good studies that have shown that the cyst itself diminishes the ovarian reserve. So it's not like the surgery is making it worse. Leaving the cyst there makes it worse already. So it's not like it's helpful if you just leave it alone. Number 2, in some cases, especially with an endometrioma or a dermoid, they only get bigger. They don't go away by themselves. And so it's only going to damage the ovary more tissue trauma when you finally do need to operate, which you likely will, and more pain and more inflammation. plus the whole endo and infertility complex. I mean, obviously, it's not great to have endometriosis when you're struggling with infertility. And then the other reason is that we know for sure that the change in the AMH and the antral follicle count is transient. So after 6 months or a year, it does come back to normal, and there's no difference between the group that got surgery and didn't have surgery. So it's a transient effect. So I don't necessarily tell my patients they all need surgery because I don't believe in cookie cutter medicine, but I do believe that patients should be offered a intelligent discussion of the risks and the benefits, and in some cases they should be offered surgery first. Now, it's controversial if your ovary has twisted whether or not you should or should not have surgery. There's absolutely no evidence on it whatsoever, but if the ovary is black because it's been ischemic for a while from the torsion, it can be very fragile tissue and therefore difficult to operate on. If it's not a really tight torsion, it's a more gentle torsion, you can get away with it without any damage to the ovarian tissue, in which case you probably should do the cystectomy. If you've torted enough times, you need to actually sew the ovary to either a ligament or the sidewall in order to prevent it from being able to twist again. That's kind of the story on ovarian torsion. Typically presents with sudden onset of very, very excruciating, agonizing pain, vomiting. The pain tends to come and go, it waxes and wanes, and it's very, very uncomfortable. So those women actually need to have attention paid to them. There is no way to diagnose torsion without actually seeing it. So we do use Doppler ultrasound where you can see blood flow, and certainly if you see no venous or arterial flow, mainly arterial, going to the ovary, you get concerned. But the presence of arterial flow does not rule out a torsion, and that's been shown in many studies. So if you have a big cyst, you've got that waxing and waning pain, you're puking, the pain is quite significant and it's terrible, you have to at least consider the value of having a laparoscopy so they can see and unflip the ovary. If you don't unflip the ovary long term, the ovary will die, and you can't have dead tissue inside you because it becomes necrotic, and that's a risk for infection. So we do need to end up removing some of those ovaries if it's been too long that it's been in there. So that's the story on ovarian torsion. Hopefully people have had some time to ask some questions. If you have questions about cysts or surgery regarding cysts, or even about any of the torsion impact, I'm happy to answer those as well, but we're just going to take your questions tonight. And I'm sorry I'm kind of grizzled, but I didn't have time to shave. Yeah, fire away.
Ready?
Yeah, I'm ready.
Okay. After 2 failed transfers, 1 artificial, 1 modified natural, doctor recommended ERA. Would you recommend estrogen PIO ERA or modified natural ERA? Pros and cons of each.
You should never do ERA. ERA has been proven in so many studies I've actually lost track now to not be beneficial at all. There is absolutely not a single study out there that demonstrates a benefit to doing the ERA. Their own study did not show a benefit. So there is no value to doing an ERA. If you're having multiple failed transfers, you should actually either look at the quality of the embryos or look at the quality of your lining or consider evaluating your immune system, but do not bother doing an ERA test. It is absolutely useless. The easiest way to know that the ERA is useless is they claim that there's this 6-hour window. In fact, in some places they say 3 hours. So 3 to 6 hour window of opportunity to, or of implantation, within which you have to put in the embryo or it won't work or won't give you the same success. So there are lots of studies that show that there's actually no difference in success rates if you put in a day 5 embryo after 5 days or 6 days of progesterone. It makes no difference. And we do that here all the time because if the lining isn't compressed enough, they haven't gotten enough progesterone, we go an extra day with the progesterone and we don't see a difference in the outcomes. So that idea that there's only 3 to 6 hours is total nonsense. It just absolutely is not true. I was a hardcore devoted ERA fan. I adopted it very early on. I kind of fell for it hook, line, and sinker. It made a lot of sense biologically to me, and the reality is it actually doesn't work. Why it doesn't work, I don't know. I wish I did, but it actually doesn't work. So save your money. Do not do an ERA. It's totally useless. You're better off figuring out what's wrong without doing an ERA and then going ahead with that. And endo can be a cause of failure. So surgery is one of the things we consider when our patients have had more than 1 or 2 failures.
What percentage of embryos would be euploid at 31? How many live births would you expect with 4 embryos?
So a third of them will be abnormal. 25 to 30% will be abnormal at 31. So if you have 4 embryos, you would think that probably 1 is abnormal and 3 are normal. There's a good study from Richard Scott's group that demonstrates that if you have 3 euploid embryos, genetically normal embryos, it gives you a 95.2% chance of 1 live birth. 84% would be 2 if you assume there's a 50% per embryo implantation rate. So you should be able to achieve somewhere between 1 to 2 live births with 3 genetically normal embryos.
Do you see a difference in live birth rates between an embryo graded 4 AA and an embryo graded 4 BB?
Yes, there is a subtle difference. And there's a study we reviewed on the show probably 2 months ago, which did demonstrate that even subtle changes in morphology does have an impact on the outcome. So that is something that plays a role. It's not a huge role. It's really below BB where we start seeing drop off. So there's not a big difference between a BB and an AA, but there is some difference between a BB and an AA. Not huge. You'll still get very, very good success rates with both.
Are your patients able to travel outside of the country for a mini vacation and continue receiving treatment upon return?
If you are going outside of Canada for a non-essential purpose, to the best of my knowledge, Ontario is still locking people down when they come back in a quarantine if it's a non-essential visit outside. However, I think it's changing very quickly, and what you say is essential is totally up to you. So if you're double vaccinated and you've left Ontario and you're coming back in, as long as you test negative for COVID, they're not making you quarantine anymore. But that's assuming you're going over there for a non-essential purpose. For an essential purpose. If you're going for a non-essential purpose, I don't know what they'll say to you when you come back, but I think they're opening it more and more right now.
Had a recent miscarriage chemical at week 5 with a PGT tested 6-day embryo. FET took place after 5 days of progesterone exposure. Do you know what might have caused this? Progesterone exposure too short?
Could be. So the study we reviewed, which on our YouTube channel says 6 or 7 days of progesterone, which one is better? So it's actually 5 days or 6 days of progesterone. We got to change the title on that one. So if you transfer on day 6 with a day 6 embryo, the miscarriage rates are higher than if you transfer after 6 completed days of progesterone, which is day 7. So they did demonstrate a higher rate of miscarriage. So with day 6 embryos, we go the extra day of progesterone. And that's another reason that ERA test is useless. So yeah, we focus on the stage of the embryo and then select our progesterone dosing based on that. Keep in mind, a genetically normal embryo could miscarry for multiple reasons. It could be genetically normal, but still be single gene genetically defective. So for example, if you have multiple single genes that are not normal, it may impair the ability of the embryo to develop. You could have a very energy inefficient embryo. That can also cause implantation failures or pregnancy losses. It could be a sperm DNA fragmentation problem. That's associated with a huge increase in the risk of miscarriage. Dr. Serena Shen posted yesterday or this morning, and I did a follow-up post talking about smoking and the impact on maternal miscarriage. Even if the guy is smoking, the miscarriage rates for the embryos are much higher because the sperm DNA fragmentation is significant. So, and we've been telling you guys that for the whole time we've done this show. So, that's really critical. It could be your immune system. It might not have anything to do with the embryo whatsoever. If you have infections in your uterus or your immune system is overactive, those can impact things as well. It could be the shape of your uterus, polyps, fibroids, again, having nothing to do with an embryo. So we have kind of a checklist of things we go through when we have failures, and I speak to my patients about each and every one of those. We figure out what they want additional testing and or treatment for, and then we move forward from there. Some patients don't want and or need anything, whereas other patients want everything tested before they go for another transfer. So you know, you have to judge by the patient and how many embryos they have. Obviously, if you have 10 embryos hanging around and you failed one, that could have been just a bad embryo, you know, and there's no reason not to try again without a whole lot of expense or fancy treatments or tests. If you only have 2 embryos or 3 embryos, you may want to do everything before you use another one because you've got a limited batch. So it depends on each patient. And again, never go somewhere where it's cookie cutter medicine. I've had a number of people messaging me during my vacation saying, I'm going to the center and my IVF can only be done at this one time. That's never going to work. There's got to be some flexibility. You may need to wait a month, but then they can accommodate you. But there should never be a time where you can't get what you need because they're saying we just don't do that. That's never going to work out, guys. You have to have a flexible program or else you're not getting good care.